Hey, Jim Hoffman here for EMS Office Hours, and this is your Monday Minutes. Today, gonna sort of do like a subtopic of a subtopic, right? Talking about abdominal trauma, and more importantly, gonna talk a little bit about the solid abdominal organs and the injuries that you might see, or what to sort of look for in patients that you might suspect a abdominal organ injury, especially when you talk about closed injuries. And we talk about solid abdominal organs, primarily liver, spleen, pancreas. I included the diaphragm as well, even though it's really a muscle. It also can get injured, and I think it's important to mention the diaphragm when we talk about abdominal injuries as well. So, real quick, some pictures here, and I look at the abdominal area here in this picture, and there's a lot of stuff going on, right? All kinds of organs in here, hollow organs, solid organs, muscles, ligaments, everything in there that can get damaged when you talk about a blunt injury or a penetrating injury to the abdomen. Okay, and you look at the four quadrants of the abdomen as well, just sort of breaking it down more of more of the gross sort of organs that are there. You can see the liver, how big the liver is, and the area that it takes up. As opposed to something, let's say, like the gallbladder, right? And where the gallbladder is located. So you can think about an abdominal injury and the types of organs when you look at an image like this, where you might suspect to see an injury. What organ might be injured in an abdominal traumatic injury? Again, whether it's blunt or penetrating. But today, I'm going to focus more on the solid organs, okay? And we're going to start with the liver. All right, and when you talk about everything involved here, okay, a lot of times what we're looking for end up relating to the size, okay, of the injury and even the time of how long ago the injury occurred, okay, because bleeding in the abdomen can be slow, right? And talk about liver, it's the largest one that's in the abdomen, okay, but it's also the most vascular as well. When we talk about the time frame, it gets about 25% of the cardiac output, okay? And because of the size of it, the location that we saw in the previous image, it ends up being really the most vulnerable, okay, organ inside the abdomen when we talk about getting injuries, okay? So you might want to suspect injury, especially patients that have sort of right-sided chest trauma or right-sided abdominal trauma. If they have a fracture, let's say, to their rib, you suspect their ribs are fractured, especially 7, 8, 9 ribs, okay, that go over the liver. All right, suspected injury there. And think about, again, I just mentioned the pictures too. You've got ligaments inside the abdomen as well. There's a ligament that's actually in front of the liver, and that can actually end up slicing the liver, especially when you talk about sudden deceleration sort of injuries that go on. Okay, so I'm not going to go into the percentages of patients that have liver injuries and all that, but it is one of the most common injuries that you might see in children. And again, it can get a contusion to it, you can get a laceration to it, a hematoma, okay, to the liver. All of that can go on, all right? And so you want to suspect that there's an issue going on with the liver, especially, again, we're talking about right upper abdomen or right lower chest areas, okay? So, again, most vulnerable, largest organ, a lot of vasculature going on there, okay? And you can have some significant injury happening there. So think about your suspicion, mechanism of injury, the deceleration, if it's a penetrating injury, where the penetration is, okay? All that take into consideration when you're assessing your patient that has some type of abdominal trauma going on. Now, the spleen, again, this could be a fall, could get injured from a motor vehicle accident, but it's really a less obvious sort of an injury, okay? And sometimes you might even have minor contact stuff like football tackle or, things like that, hockey. These types of things can cause an injury to the spleen, even though there's minor contact, okay? It's actually the most injured organ, when you talk about the abdominal organ, especially with blunt abdominal trauma, in the adults at least, and whereas the liver is one of the most common for children, it's the second most common when we talk about children. Okay, and again, we talked a little bit about time as well before, right? Where there's only maybe about 5% of circulating blood coming through the liver. Um, it does get direct supply from the aorta. All right, so these are the type of things you have to think about. And I mentioned time before because this is the type of patient, a spleen injury, where you might not see something going on for 1 to 2 hours after the injury. And that's when we talk about shoulder pain. And you say, what, shoulder pain for a spleen injury? Well, it is actually sort of that referred pain, and it's a common sort of complaint that a patient's going to tell you that they might have left shoulder pain. Okay, but again, that's not going to really start happening maybe 1 to 2 hours after the injury. So think about with the spleen, again, the mechanism of injury, deceleration. Maybe it might just be a soccer injury or a football injury or something like that. Okay, but look for those left-sided injuries. Okay, fracture of 9th or 10th ribs. Things like left upper quadrant tenderness is another one you want to look for, and of course the tachycardia and the hypotension are indicating that there's some type of blood loss going on. Now the pancreas, again, this is well protected organ. You're not going to see this a lot. It's really less than 5% of all abdominal injuries that you can see out there. Is going to be an injury to the pancreas, but because it's got that anatomic position where it's located, it is again well protected, right? It's a retroperitoneum. It's well protected from injury. So, but what happens is it takes a lot of energy. It's a high energy force that's going to be needed to damage the pancreas, and we're talking things like from a bullet, okay, something like that, or severe blunt trauma like a steering wheel impacting it, or maybe even handlebars, right, from a motorcycle, okay. So these are the things you're going to look at. Unrestrained drivers, if they're not done the seatbelt on, these are the things where you're going to start having that higher risk for pancreatic type injuries. Okay. Now, patient complaining of pain for these injuries, well, it's really kind of vague, right? They're not going to give you the severe pain. It's going to be sort of like this vague upper mid abdominal pain, maybe radiating to the back a little bit. Okay. And again, time again, right? The patient might have that irritation, that peritoneal irritation going on from any kind of bleeding and inflammation, but it's not going to be for a little bit of a while. It's going to be after the injury, okay? And that's going to get you lead you along the line. That if you get a patient, let's say that had something going on hours before, they went home, and now they're having this tenderness, this vague pain. Don't just blow it off. It might be that the pancreas was injured and whatever it is that went on with that patient. Okay. Now, I'm going to talk about the diaphragm here just a little bit because it's important to know that it is in that cavity. It's very easy to get injured. Okay. But it's important to know, and I'm sure you know this, that the diaphragm is a primary thing when we talk about the patient's ventilatory process, right? So any sort of injury to the diaphragm is going to have your patient having signs and symptoms of some sort of respiratory compromise going on there, right? Now, you don't usually, the one thing with the diaphragm as well, it's not usually just an isolated injury, which is why I'm mentioning it here, okay? A lot of times you get patients that might have a ventilatory issue or some sort of, you might suspect damage to the diaphragm, suspect damage to the abdominal cavity as well, suspect damage maybe to their thoracic area, the heart and lungs and all that. So think about the bigger picture when you've got a patient that might be having some sort of diaphragmatic injury going on, okay? But they are rare injuries to the diaphragm. You don't really see it that much, but it does result again from blunt trauma. We're talking about those high-speed motor vehicle crashes or penetrating trauma as well. Okay, so think about all this type of stuff. You get the motor vehicle accident, you sort of get that lateral sort of impact to the motor vehicle. You get sort of that twisting, distortion of the patient's body, which can end up winding up shearing or tearing the diaphragm. That's when you're going to sort of see this sort of injury. And then again, the frontal impact where you get the steering wheel or the column of the vehicle as well, causing injury to the diaphragm. So just think about, these are just things to think about, guys. Pretty much your treatment is going to be the same for all of these organs, right? But maybe the diaphragm might be a little more aggressive when it comes to the airway and ventilation, as opposed to, let's say, a pancreatic sort of suspicion, right? But you're going to assess your patient and take your vital signs, and you're going to go from there. So when we talk about treatment, well, we got our BLS care, of course, right? You're going to talk about giving them oxygen, making sure the airway is open, spinal precautions, okay? All your first step, right? And you want to think about, again, non-rebreather mask, right? At least at the basic, when you talk about, and this is for patients that are having these signs and symptoms of having something going on. Okay, I'm not a big fan of just shoving oxygen in everybody. I'm not a big fan of just spinal mobilizing everybody. But you got to follow your local protocols, follow your local guidelines. And of course, when it comes to abdominal treatment, there's not a lot we can do. We cannot go in there and stop bleeding, but we can do the basics, which is just oxygen, this immobilization, maintaining that airway, especially talking about things like diaphragmatic type injuries. ALS level, just going to pretty much it's fluid. Of course, we're going to put them on a monitor. We're going to probably do it end-tidal SpO2, maybe end-tidal CO2. Again, depending upon what your equipment you have, what's available to you, what your protocols are. But these are basic ALS interventions that we're going to end up doing. But you're going to think about giving trauma treatment to a patient, which usually is 2 large bore IVs going on, usually normal saline or maybe even liquid lactate. And you want to keep that pressure, between 90 and 100 systolic. Okay, guys, don't delay transport to sit there initiating IV access. Try to do it around to the hospital, and think about what hospital you're going to be going to, guys. Does the patient need a trauma center? Can I go to a regular hospital? Think about that when you get there. What is that hospital going to be able to do for that patient? Okay, can I do emergency surgery? Can I do traumatic sort of injuries? Okay, especially if you have a high suspected indication that something in the abdomen is going on, the liver is bleeding, or the spleen is bleeding, or you've got a diaphragmatic injury going on, right? Where you're going to have a lot of blood loss, shocky patients, things like that, okay? And again, transport them to the right hospital, but I think the key, guys, is when you talk about abdominal injuries, patients that you get into motor vehicle accidents or might have a penetrating abdominal sort of injury, maybe they're not presenting with anything that clear cut right off the bat. But think about your reassessment, guys. A lot of times, by reassessing your patient a few times, over and over again, the mental status, their vital signs, pain scales, things like that, this is what's going to sort of help you discover a patient who might have a worsening condition going on that maybe you didn't catch upon your initial assessment. Okay, so guys, please reassess your patient. Don't just do the first assessment and then that's it. Keep reassessing them, especially if you got that strong indication that there might be some sort of an injury going on based upon the mechanism that you might have seen or been told about prior to your arrival. Pain management, again, talk a little bit about your local protocols and what you can and can't do. Pain management, it depends. Sometimes, you get people who say give pain management no matter what. You get other people who might say that not to give it because when it comes to abdominal sort of injury, it masks sort of the injury, and also because of the causing that a lot of times morphine, things like that, can give a patient hypotension and sort of confuse that reassessment that you're doing as far as what you're finding, okay? But again, local protocols you want to follow, guys. When any question, contact the doc. Let them know what's going on. Tell them the patient's in pain. Dr. Field is warranted. He'll go ahead and give you that pain management, okay? That's at least one thing we can do in the field, guys, that really can help people is giving that pain management. But again, if you have a doctor or your system is in that mindset of that pain management can mask signs and symptoms of abdominal injury, you might not be able to do it, okay? So that's what we have to deal with, guys. This is sort of the cards we get dealt in EMS, unfortunately. But you got to follow your protocols and what it is that you're doing, okay, out there in the field. So, pain management, again, you're going to go by your local protocols and what you can and can't do. Okay, guys? Well, that's it. I'm going to end it there because these are just some quick minutes just to sort of give you some key points, I think, and some key ideas and what to think about and what you're looking for with these types of solid organ injuries in the abdomen. Okay, so I hope you can use some of these Monday Minutes, guys. Listen, I've got Turbomedic. I'm going to just mention this real quick, but if you really do, guys, if you want an all-in-one study training resource out there that you can actually turn to in order to pass any exam, you can perfect your skills, master your clinical expertise, master the way that you're assessing your patients and coming upon your diagnosis and what you think a patient may or may not need. Go check out Turbomedic, guys. It's got everything there, from download files, there's audios, there's videos, there's even web apps now, and a lot more, including live interaction with other members and myself when we do the Turbomedic Insider video webcast. So really, guys, it's really guaranteed to take you to another level in your EMS career. Okay, it's going to really start building knowledge base, guys. Go out there, learn the information, get a solid understanding of it, and then you'll be walking into every exam, every patient encounter that you do with confidence. So go check it out. It's turbomedic.com. Get all the details there. There's everything from a free level membership up to an annual membership as well. So go check it out, guys. turbomedic.com. So again, guys, I hope you can use these Monday Minutes. If you have some of your own that you'd like to see here on the video cast here, send them over to me. My email is admin@emsseo.com, and you can go check out other Monday Minutes over at emsofficehours.com, and also right here at YouTube as well. Please go ahead and comment, guys. I want to hear what you have to say, what you're thinking about what we're talking about here on the Monday Minutes and other videos we're doing here at EMS Office Hours and at emsseo.com. Be sure to go ahead and let me know. So until next week, guys, as always, Jim Hoffman, stay safe.